To get started, I'm going to be telling you about PROs, which you may not have heard of before. Right now, PROs are really a research tool and are starting to affect clinical trials and will affect clinical trials a lot more in the near future. And we're going to get under the hood a bit with how we measure IBD and how the FDA thinks about IBD, and then bring this back to how it could potentially affect the way we treat patients in the future. So let's get started. PROs are patient-reported outcomes, things that the patient knows and can inform you about, symptom severity. They're different from what are called ClinROs, and these are sort of FDA terminology, what the clinician reported outcomes. So the clinician assesses this patient as having severe ulcerative colitis, as Dr. Crohn will tell us about. Or an observer reported outcome, and this is more often in pediatrics or geriatrics, where a trusted observer, like a caretaker or a parent, will report how a patient is doing. Biomarkers of inflammation, things we use all the time in IBD. The CRP is 15.4, the fecal calprotectin is 980, objective markers that inflammation is going on. And of course, endoscopic improvement, that we can see a change in the appearance of the mucosa over time, suggesting effects. There are different ways to measure what's going on in inflammatory bowel disease. All of these are valid ways to think about it, and the FDA has different views on how they can and should be used. Now, we use PROs in IBD all the time. When you have a patient come into the office, it's not unusual to ask about pain, urgency, blood in the bowel movements, the number of bowel movements, or for patients with upper tract disease and obstruction, as in Dr. Khan's case soon, the episodes of vomiting. So all of these things are things that we do all the time, and that's pretty obvious. That's part of what clinicians do. The idea of a PRO measurement instrument is to structure and standardize this for use, largely in clinical trials. So why does the FDA want us to do something new? What's wrong with the old endpoints? Well, the biggest example is Crohn's disease activity index, which people have been complaining about for years because it's not very helpful. It's very noisy. There are many methodologic flaws in how it was built. It was basically a collection of symptoms and signs that was fitted to a physician global assessment. So to some extent, it's matching a physician global assessment. It throws a lot of things together, and good drugs are identified in spite of this instrument. It clearly does not correlate well with current inflammation, and if I can get this pointer working without showing off a fabulous tremor, this is a measure of endoscopic activity from 0 to 35. This is a CDAI from 0 to 600. Ideally, there would be some correlation here that it would vaguely look like a straight line, pretty much. In fact, it looks pretty much like a cloud. It's a disappointing cloud, actually. And it just shows that what we're measuring a lot of things, but we're certainly not measuring active inflammation in an accurate way. So in terms of the old endpoints, one of the most disappointing findings recently, and this is to look ahead to Dr. Kanukin's talk this afternoon, the CDAI was shown to significantly decrease in response to marijuana without increase in inflammation. Patients felt better, and the CDAI measures everything about Crohn's, including whether patients just feel better. And the FDA has declared the CDAI dead to them. It is no longer going to be used in clinical trials. We're going to have to do something else. And in effect, they've blown up the bridge. And Bruce Sands liked to say that they've forced us to cross over to the PRO world, blown up the bridge behind us. The CDAI is dead. It's as if we were forced to convert to the metric system, and they blew up Ingres measurements. And that makes drug companies and people developing new treatments for IBD a little bit uncomfortable. In terms of ulcerative colitis, there are also issues. We typically use the Mayo score, which combines 4 components: endoscopy, the physician global assessment, stool count, and stool blood. But it has its own issues. And you often hear about the 2-part Mayo, which is the stool count and stool blood, or the 3-part Mayo, which includes the physician global assessment. Those are highly correlated with the entire Mayo score. So you'll hear about those occasionally in reports of clinical trials. But in terms of the endoscopy component, it's very easy to say 0, completely healed, and 3, very severe. But 1 and 2 are actually pretty challenging, and that's where recordings and central readers come in. And there's limited dynamic range, and there may be a new instrument coming, the UCEIS, which may help a bit in this area. The physician global assessment is a bit vague. There are up to 7 or 8 criteria depending on the trial. It's multi-barreled. There are multiple things the physician is supposed to keep in mind, and it's a bit redundant. It correlates highly with endoscopy. And in terms of clinical trials, it's eminently gameable. If you know a patient needs a 6 to get into a trial and you know the other scores, well, you know that their PGA has to be a 2, and you might give them a 2. The FDA has really been discouraging about this, and it looks like this PGA component may go away in the future. The stool count is challenging. It's defined as normal versus 1 to 6 bowel movements more than normal, but defining normal in an ulcerative colitis patient is pretty darn hard. And depending on how the patient is thinking about what is normal, this can change from day to day and can be very noisy and make for a bad instrument. Stool blood is another problem area. 0 and 3 are okay, but 1 and 2 are what we call double-barreled. You're effectively measuring 2 different things at the same time. The 1 count is streaks of blood less than half of the time. The 2 count is mostly blood more than half of the time. But if you're having streaks of blood more than half of the time, or mostly blood less than half of the time, it's not clear what the patient should do. And that, again, creates noise in the instrument and problems. So there are a lot of fundamental issues with this that the FDA is not thrilled with, that eventually we'll probably see changes here as well. In terms of another instrument commonly used, IBDQ, it's designed to be a 4-domain quality of life instrument with bowel, systemic, social, and emotional components. There are problems as well. There are actually, if you analyze the way the data separate, actually 5 domains it breaks out into. There are double-barreled questions. A classic one is, are you afraid of not finding a bathroom or a washroom, because it's a Canadian instrument, in time? It's not clear if that's an emotional component because of the fear, or a bowel component because it's really about urgency. And it really comes down to which one is the patient answering. You don't really know what's going on in their head at the time. There are a lot of issues with the items and the number of items. Ideally, you'd like a shorter instrument that would be faster to take. And in terms of methodology, it wasn't developed per the FDA guidance on PROs because it didn't exist when this was developed. This is really a new area that's taken off, and the FDA is pushing this pretty hard. So where does the FDA stand, and why is this coming now? Well, the FDA built into their charter has a number of key things that affect how they think about PROs. They want to bring to market treatments that are safe and effective, and they define effective as producing benefits that are meaningful to patients. And by that, they define it has to affect how a patient feels or functions or improve survival. And most of the time, we don't change survival that much. But we do have big effects on how patients feel or function. Endoscopy is considered a surrogate endpoint, and it's not sufficient for drug approval. You need evidence of improvement of how patients feel and function. And so the FDA issued a guidance for developing PROs, patient-reported outcome instruments, but they've been really slow about it. In fact, since 2009, in 6 years, they've actually approved 1 instrument, ExactPro for asthma. They are close in the IBD field, but it's been a very slow process. But the carrot in all this is that qualification allows labeling claims. So for people developing drugs, you might be in phase 1 or phase 2, getting this news from the FDA feels a little bit like this, that the bridge has been pulled out from under you. And it has made folks involved in this field in clinical trials and in drug development very, very anxious. So why PROs and IBD? Well, part of it's the FDA goals. Part of it is that the bridge back to the CDAI island has been mostly destroyed, and I'm going to tell you a little bit about PRO2, which is a little bit of a temporary fix. But it allows things like labeling claims, and I'm not going to claim this is exactly what the FDA will allow, but something like Amazing Mab, and that's my trademark, nobody can use it, I'll have to change all my slides. Significantly improves the signs and symptoms of Crohn's disease that matter to patients after 4 weeks of treatment and maintains these improvements at 52 weeks. This is something of value, and this is a carrot for people developing drugs in this field. So the FDA, and I'm going to give you, believe it or not, the shortened version of this, requires somebody developing a PR instrument to go from conceptual models, patient focus groups, scale development, developing an instrument, and then testing it on patients and doing continuous improvement. And this painful step right here is actually what eats up years of your time. But if you get it right, patients really feel like you're doing something important, that you're addressing the issues that matter to them. And then do quantitative validation, show that it's responsive to change and reproducible, and develop scoring cutoffs and tests and actually achieve FDA qualification. So currently in our PRO pipeline, both CDPRO and UCPRO have been developed per the guidance. Qualitative data have been accepted by the FDA. Quantitative data are going in the fourth quarter of this year, possibly being pre-qualified by the first quarter of next year. No guarantee on timeline. I'm not the FDA. But we will hopefully develop cut points of response or remission and have these being tested in the wild next year. So you may start to see these first in clinical trials and then eventually being brought into clinical practice in forms I'm going to show you a little later. The other interesting thing that we tried to do about this is rather than what the CDAI did with lumping everything together, we've tried to make these modular, a bit more like the IBDQ, with bowel signs and symptoms, systemic symptoms, emotional impact, coping behaviors, and impact on daily life. So in terms of these are the kinds of things you see. Again, this is a little bit of Dr. Obvious, things you normally ask about in a clinic visit. One interesting point that came up as we've done our preliminary data analysis, trying to break these into domains and showing that domains work, is that at least in our preliminary data, there seems to be a separation between the bowel signs and symptoms and the functional signs and symptoms. So we may actually come up with a functional domain. And if you have an anti-inflammatory drug, you might actually measure this domain, whereas if you have something functional bowel symptoms, you might end up measuring that domain. It remains to be proven that we truly have two separate domains. We also measure things like impact on daily life, emotional impact, coping activities, things that aren't directly related to inflammation but are important to patients and are important to know really what's going on with your patient. And in terms of development, we are at the quantitative validation phase. We'll have data back by August, so this is coming soon. But for the folks feeling like their train is going off the bridge, what is the FDA doing now in terms of clinical trials? Well, rather than shutting everything down, they've come up with alternatives, and there's sort of a temporary co-primary endpoint that you're probably already seeing in clinical trials now, combining an endoscopic, the SES-CD, objective marker of inflammation, and the PRO2. That's sort of our temporary thing. It's not a validated PRO, not developed per the FDA guidance. What it is actually the liquid stool count and the pain scale, two items from the CDAI. Now, I just told you the CDAI was dead, but to some extent, this is just a temporary measure to keep things going in terms of drug development. And fundamentally, the CDAI goes back to the physician global assessment, which is fundamentally part of the original problem. So this is going to be something to keep us going in terms of drug development, but not the long-term solution. And I think where the FDA is going is they want to see both objective improvement of inflammation and a qualified PRO to prove that the patient is feeling and functioning better to be able to approve a drug, to have this co-primary endpoint. So how would these work? And I think everybody in the field has been a little bit nervous about what the numbers would look like. Would it make it more difficult to do clinical trials and to prove a benefit of a good drug? So with a co-primary, as opposed to a composite, you have to have both the objective marker and the PRO met. So it's an and function. The recent example, this is one that Bruce Sands presented at ECHO 2015 with MedI 2070, a new anti-IL-23 monoclonal. And using this CDAI response endpoint, their primary endpoint, they showed a significant difference, 49% success with drug compared to 26% with placebo. But then they did sort of in a post hoc experiment. What if they used a co-primary endpoint? And they defined it as CDAI response plus a 50% reduction in either CRP or calprotectin. Some patients had high CRP coming in, some had high calprotectin, but whichever they had, 50% reduction. And it actually cleaned it up a bit. They had 42% versus 10%. So you actually, in this case, had a better outcome with the co-primary endpoint, and that may actually reassure a lot of people that this is a reasonable approach. So kind of moving to the future, beyond clinical trials, how will this actually affect clinical care in IBD? Where will PROs fit in? How will it potentially help us or hurt us? I think there are three potential applications beyond clinical trials. First, in the IBD clinic, In quality of care measures, much like Improved Care Now is done for pediatrics, and in future IBD research. Let me tell you a little bit about those. Here's an example of what the ePROs look like in use. Currently, these are on PDAs. A module will present the basic question and set up the question in the last 24 hours. Ask the patients, are they having a particular symptom, blood in their bowel movements, yes or no? If they say no, they move on so they can get through it very quickly. If they say yes, it asks for a little bit more detail on a rating scale. So they can go through it very quickly, and if they're pretty facile with their mobile phones, they do this in about 1.7 minutes on average. What we'd like to do is move these to apps so patients can record these, do them without being locked to a PDA, and in fact share them with you, and move them to the EMR. And this is an early application we have on an iPad where we're actually asking the patients through a simple survey to answer these questions, pretty much the routine questions you would ask. But rather than bringing in just the numbers, bringing in a paragraph, taking a page from Brennan Spiegel's work, and giving you a quick paragraph that pulls into your note immediately to give you the basics on what's going on with the patient when you walk into the room and pull up your note. And then you can go into more detail and say, Mr. Jones, it seems like you're doing pretty well. Is there anything else going on I need to know about? And for this ulcerative colitis patient, they're doing okay. They've got a little bit of urgency that might be worth following up, but generally doing well when you just walk in the room. So I think that's a little bit of a carrot for the clinician trying to get through a busy clinic. Also, we can apply this to quality of care measures. Now, we measure how well our patients are doing now with biomarkers and endoscopy, measuring the inflammation. We don't necessarily currently objectively measure or follow how patients are doing in terms of PROs, how their pain is doing, how the impact on their daily life is doing. We do it in a very qualitative way and talking to the patient and asking them how they're doing. This can structure it in a way and can focus visits, if the patient has filled this out in advance, to focus visits on the issues patients care about. And in terms of population dashboards, and this is an approach that's being used more and more in pediatrics, to look at which patients are having trouble, where they're having trouble, and not necessarily waiting for the visit to intervene. So if you can look at a population dashboard and see how you're doing over time in terms of bowel signs and symptoms, are patients reaching remission? Are most of your patients reaching remission? If they're not, can you intervene? And their interventions might be different for different patients. So for example, patients with obvious inflammation, of course, there's anti-inflammatory therapy. But beyond those patients, the ones who don't have active inflammation and still have symptoms, they might need a low FODMAP diet or stress reduction and counseling, and targeting towards where they're having trouble. If their emotional domain is part of the issue, they may need counseling and stress reduction that would really make a difference beyond what you can do with medications. There's also an opportunity here that I think we can approach that in future IBD research. Currently, all of our therapies and research are focused on inflammation, which is certainly the first step in inflammatory bowel disease. But going beyond that, when inflammation is controlled, symptoms are still present in about 30% of IBD patients. And those are the patients who keep coming back, who keep calling, because your anti-inflammatory intervention is not giving them the quality of life they'd like. And what we often do is resort to empiric therapies with minimal evidence in IBD. Pull out the Levsin or the Bentyl or whatever your agent of choice might be. But if you can't measure something, you can't improve it. So the idea is to be able to have a structured measurement and be able to actually do trials to test whether we can change outcomes in these aspects of IBD beyond inflammation. And here are some examples. We know patients after severe inflammation have intestinal hypersensitivity. You might be able to target TRPV1 vanilloid receptors, and there are drugs in the pipeline for this and affect this pain and hypersensitivity. For dysmotility, certainly we know that 30% or more of Crohn's patients use marijuana, and Dr. Kanukin will talk about that this afternoon, but perhaps specific, pure, and safe cannabinoid receptor antagonists can really make a difference in the functional domain. For small intestinal bacterial overgrowth, very common in the kind of patients we'll hear about in case 1, you might be able to do pH7 release defensins and affect the microbiome and change someone's outcomes. For fibrotic strictures, one of my research areas, a myofibroblast inhibitor may be very effective in actually changing bowel stiffness and perhaps reaching the point that we could treat strictures medically rather than surgically. Again, that's a long ways away. And for anxiety and distress, measuring things like the emotional domain and being able to intervene. Certainly cognitive behavioral therapy is where we are now, but there are certainly a lot of other agents that may be helpful in affecting the emotional component of IBD and the sort of PTSD-like experience of waiting for the next flare to occur and wondering how this will affect your life. And Dr. Zegathy will talk about that this afternoon. So endpoints in IBD are changing quickly. The SCSCD and endoscopic and a PRO2 is our temporary bridge to keep clinical trials going. But in the long term, the FDA wants PROs that measure outcomes that are meaningful to patients, which will affect labeling claims in clinical trials. And being able to measure things that are meaningful to patients in a consistent way may actually help to improve our clinical care in the long run. PROs can be used in EMRs and population dashboards, integrating with EMRs, and PROs and flexible modular endpoints could allow trials and approval for IBD therapies targeting other aspects of IBD beyond inflammation. And I'm hopeful that we may be able to make a lot of progress in the areas that Dr. Zegathy is going to talk about this afternoon to really improve the quality of life of patients once we've really controlled inflammation. Thank you very much.